Hello, welcome to a WCC webinar. We are doing a COVID update. My name is Reverend Brianna Ilene. I am the Wisconsin Council of Churches Content Curation and Ecumenical Innovation Coordinator, which is a long title, but it means I get to do lots of things, such as having these conversations. And I am joined by two great gentlemen today who will introduce themselves in a moment. As we get going, I want to invite you as this webinar is happening. If you have a question, especially if you're with us on Zoom, I'll try to keep my eyes on Facebook as best I can. But if you're in Zoom, go ahead and drop it in the Q&A section, and we will try our best to get to some of the questions that people are wondering, just so we can help make sure that we're sharing information that is relevant to you. So I am going to pass it over to Dr. Swain and ask that you introduce yourself.
Yeah, thanks. Good afternoon, everyone. Thanks for joining us. I'm Geoffrey Swain. I'm a public health physician. I served for 26 years as the medical director for the City of Milwaukee Health Department, and also for most of my career as a faculty member, first at the Medical College of Wisconsin, and then for the last 15 years at the UW School of Medicine and Public Health in Madison. I'm retired for the last 2 years, but still very active in public health as a volunteer, and including helping with COVID response. And I'm also the president-elect of the Wisconsin Public Health Association. So I'm really pleased to be here. Thanks for having me.
I guess Brianna's going to let me introduce myself here. Hi, I'm Dan Schultz, the Wisconsin Council of Churches Community Health Program Director, which means really at the moment that I lead the vaccine team, and encourage you all to get vaccinated and boosted, and host vaccine clinics in your congregations if you're willing. We are so glad to have Dr. Joff back with us. It's been a little while since we've done one of these, and with the emergence of the Omicron variant, it seems like a really good time to get back together and fill everyone in on how things are going. So, Dr. Swain, I think this is at the top of everyone's list of questions these days. What do we need to know about Omicron?
Well, thanks for that, Dan. I think the first thing we need to know about Omicron is that we were in enough trouble without Omicron, and that we're still in very serious trouble right now in Wisconsin with regard to the pandemic. And Omicron will be coming to Wisconsin. It's possible that it's here already. We haven't detected it yet, but nonetheless, the vast majority of our cases right now are still due to Delta. Delta is very bad, and it's giving us a very hard time. And so even before we get to Omicron, I think, the most important thing to know is we're just in a bad spot right now already. I think people, if you look back to, say, June this past summer, things were looking really quite good before Delta hit. And I think pretty much most people, and I was among them, were feeling like, gee, we might be getting out of the woods. And then Delta came, and we got ourselves very deeply back into the woods. And but unfortunately, a lot of folks, started, well, at that time it was reasonable to start to loosen up on some of their caution around personal behavior, mask wearing and gathering and that sort of thing. But unfortunately, as Delta ramped up, a lot of people didn't go back to those previous more careful habits. And that, combined with the fact that we still have a large percentage of our population that's unvaccinated, really has led to this serious spread of Delta. With regard to Omicron, we don't really know enough yet. It's still quite new on the radar, and a lot of people that are a lot smarter than I am are working very hard to try to answer a lot of questions about Omicron. It looks very worrisome. How will it play out? We don't know. Will it, Will it be a lot worse than Delta? Let's hope not, but it might be. Will it evade vaccination immunity to some degree? Let's hope not, but it might. But those questions all remain to be seen, and they're going to be answered, in the coming weeks, in the next couple of weeks. But as for now, it's very worrisome, but we already have plenty to worry about with Delta.
Yeah, we were talking just before we went live, and you said that they've confirmed 5,000 new cases.
Yeah, today was a bad day in Wisconsin, but actually the last couple days have been bad. We had a little break over the Thanksgiving holiday, but that's mostly because not very many people were getting tested. But today they confirmed 5,097 new cases. That's the most that we've had in over a year. And a year ago, if you remember, we were in the throes of the worst part of the pandemic in Wisconsin, and that was before vaccination. Like, we are almost getting back to the point we were at before anybody was vaccinated. And equally concerning is that we have a very high test positivity right now. The average 7-day average of test positivity as of today, as of yesterday, in Wisconsin is 13.4%. That's ridiculously high, and it really does not send a good a prognosis for what the next week or so may look like.
Yeah, as a reminder for folks, the unsafe level that we set at the WCC for our guidelines starts at 10%, and now we're at 13%. But since we're talking about confirmed cases, could you perhaps walk us through the difference between confirmed cases, probable cases, and suspected cases, and I guess why we should care about that?
Yeah, well, I think we should care about that. If you look on the dashboard, the main dashboard webpage for the Wisconsin Department of Health Services, they do report every day the number of confirmed cases and the number of probable cases, and they give a 7-day average. So they don't actually list or delineate the number of suspect cases. And this is getting a little bit into the weeds of like public health jargon, but it probably is important in some way. So a confirmed case, that's pretty obvious. That's a person who has tested positive and has no reason to believe that test is wrong. So really you can count on the number of confirmed cases as really being actual disease. Probable cases are typically people who have symptoms that are consistent with COVID, or mild symptoms but a known exposure. So they're very likely to have COVID, highly likely, but either they haven't tested positive yet, they've tested, but their test results haven't come back yet, or they haven't tested yet. So we put them in the probable case. Not all probables become confirmed, but the vast majority are. And so from a public health point of view, practically speaking, we treat them the same. If you're probable, you need to isolate just the way you would if you were confirmed. If you've been exposed to a probable case, you need to quarantine just the same as you would if you'd been exposed to a confirmed case. Suspect cases are a little different. That's someone who, has a little sniffles or some, kind of atypical symptoms. Maybe they've had an exposure, maybe they haven't. We haven't tested them yet, or we don't have their test results back. And it's not really clear that they're likely to have it, but they might. So that's why we don't count suspects in with the rest of these. It matters also because, a lot of people are looking at what is the burden of infection in the community, and we measure that by the number of cases per capita, and more precisely, the number of new cases per 100,000 people per day, averaged out over a week. And if you look at the confirmed cases, that's going to give you one number. If you add the confirms and the probables together, that's going to give you a bit higher number. But to give you an example, as of today, the updated today, probably the most recent is yesterday's data, there were on average 3,015 new confirmed cases per day in Wisconsin over the last week, and another 554 probable cases. So most of the cases are confirmed cases. If you add in the probables, it probably adds another, I don't know, 10%, or I'd have to do the math a little more quickly on a calculator. But it's not a trivial number. But at the same time, if you only are looking at the big number of confirmed cases, that's going to give you the bulk of what's happening.
One thing I learned in a briefing this afternoon is that if you're hospitalized for any reason and you fall into that probable category, they have to treat you as though you have COVID. So you go in for gallbladder surgery and all of a sudden you have to isolate, and that affects outcomes for being in the hospital. And that's one of those sort of hidden burdens on the healthcare system. So what sort of data should we be watching these days?
Well, I think one thing that's come up, and I know you may want to ask more about this over time, but I think, a lot of people, and, I'll count myself among the people that are tired of COVID. Look, I'm really tired of COVID, and, pretty much everybody I know is. Sadly, COVID is apparently not tired of us. But just because we're tired of COVID doesn't mean that, we can, we wish it would go away, but wishing it would go away doesn't mean we can wish it away. And I think some people are wondering, are we to the point where COVID is sort of at its background level now? The idea that COVID is never going to go away, and it's never going to go away. So when can we just think about it as background noise and go about our lives? And that's going to happen sometime, but we are nowhere close to that right now. And so what can you look at? To get back to your question, what are the data that we should be looking at to kind of get a handle on that? Well, the first thing is how many cases, and we've got a lot of cases, really a lot. Right now, we're, with that 5,000 new cases and 3,000 a day on average, we're over 50 cases per 100,000 people per day on average. That's a lot. That's super high. And so that's the most important thing to look at. The second thing that we are looking at, and that I encourage people to look at, is what is happening in hospitals. You just brought up hospitals a second ago. Well, what's happening in hospitals? Right now, hospitals in Wisconsin are in some trouble. Over 2/3 of Wisconsin's hospitals are at or above the peak capacity for their intensive care units. That's a problem. And it's not only a problem for the next person that needs to go to the intensive care unit because they've got severe COVID. It's also a problem for the next person that has to go to an ICU because they've had a heart attack and a bypass, or they've had cancer surgery, or, a car accident, or any number of farm accident, any number of other things that sort of happen all the time. So watching hospital capacity, and our hospitals are stressed right now. They're not as bad as some other places currently are, like Michigan, or some other places have been recently, like Idaho or Alaska, but they're not good. So that's the second key thing. And the third thing has to do with our vaccinations, our overall rate of percent of our population that has completed their vaccinations. And as of today, the percent of everyone in Wisconsin that has completed a COVID vaccine series is 56%. So this is ticking up a little bit every day by 1/10 or so, but that's not anywhere near where we need it to be, even with the original COVID, and it's certainly not where we need to be with Delta, and presumably not with Omicron either. We can circle back to the issue of vaccines against Omicron a little bit later. But we need that vaccination rate to be much higher. And that's actually reflected in the WCC guidelines for returning to church. One of the things that you have in there that I think was really wise is, are vaccinations in the sort of up to 50% range, or are in the 50 to 70% range, or 70 plus? And looking to be at 70 plus is really where we need to be. And once we start to get there with 70, 75% of the population vaccinated, then what I think we're going to see is that we may still have a lot of cases because there are breakthrough cases. People are getting infected even though they've had their vaccination. But we're not going to see as many hospitalizations. These breakthrough cases usually are mild, especially if you're a healthy person, you're not too old, or you don't have underlying medical conditions. And so even at that point, when we have a high rate of vaccination, we may have a high rate of cases, but our hospitalization stress is going to be much lower because most cases will be mild. That's the point where you can start to think about, is this endemic? Is this starting to get to be background noise? Is this like where we're going to end up living with COVID? When COVID gets to the point where the vast majority of cases are mild, then from a public health point of view, we don't care so much about it, and churches shouldn't care so much about it, and businesses shouldn't care so much about it, but we're just not there now. We have to get a higher level of vaccination rate, and we'll know we're getting there when we see that and when we see hospitalizations going down substantially from where they are now.
Well, what in the meantime, what kinds of precautions should people be taking? We hear a lot, in particular from churches, asking, well, what if 100% of the people in our congregation are vaccinated, or 100% of the people in our choir are vaccinated? Can't we relax these precautions a little bit?
I'm glad people are thinking so carefully about this. And I'm also glad if people really do have that kind of data about their local congregation. It's really important. And at the same time, right now, I'd have to say, I don't recommend relaxing, even if you have a very highly vaccinated or even completely vaccinated group. And that's not just my opinion. To give you a concrete example of that in public health circles, recently the American Public Health Association had its annual meeting in Denver. Normally there's 12 or 13,000 people that attend that. This year there were about 4,000. They required everyone to prove vaccination before you walked in the door. And so they knew 100% of the people in that convention center were vaccinated. It's a large convention center. 100% are vaccinated. They still made us wear masks, 100%. You had to wear a mask all the time. And they still had cases of COVID transmission. Now, hopefully they were mild because people were vaccinated. But that's the problem. There's breakthrough infections even among people that are vaccinated. And you may know that your congregational members are 100% vaccinated, but what don't you know? You don't know about their households. You don't know about their workplace. You don't know whether they have people in either of those settings or their other social circles who may have been vaccinated but are elderly, so they're still at risk, or they're immune compromised for some other reason. You don't know any of that stuff. So right now, with all the virus that's circulating, this very high level, even if your local group is 100% vaccinated, please continue to wear masks. It's so important.
I think that's important too, that I often find myself frustrated of but everyone I know is vaccinated, or I'm vaccinated, I did the thing, but this, shouldn't we be good? But that idea that the virus is circulating at such a high rate. And I think that's just a good reminder in this of we need to bring those levels as the levels of COVID as a community down before we can actually kind of ease up and live into the joy of vaccination.
Yeah, I couldn't have said it better than that. Thanks.
Do you have,
Sorry, I was just answering one of the questions in the Q&A, and we had another one from Carol, who asks, how do we account for natural immunity in the calculation of when this virus will be counted as endemic? And if I understand the science right, Dr. Joff, we we don't really track the natural immunity. It's when those hospitalizations go down that really makes a difference.
Yeah, so it's a really great question, and I'm so glad it was asked. Thank you for that. Because what we can track is vaccination status. It's a lot harder to track. Like, we're not doing antibody testing on everybody on a weekly basis, so it's really hard to know. Like, but you're right. The person asking the question is correct that actually the real key thing here is not how many people are vaccinated; it's how many people are immune. That's true. And we certainly have people at any given time who are immune because they've been recently infected. And those people are not likely to get infected again, with the big exception of Omicron seems to have a better propensity for being able to cause reinfection. But in general, you can say that someone that's been recently infected, for a while anyway, they're immune. So when I say I'm looking for a vaccination rate at least 70%, I've got in my mind, but I'm glad you're having me make it explicit, that there's another 15 or 20% of people, let's say, that are maybe not vaccinated, but they've got natural immunity because they've been infected. And that's getting your overall population level of immunity between vaccination and infection up to 85, 90%. That's what it's going to take in the community to bring down the spread of this virus because it's so infectious. And so, yes, it plays an important role. The problem with relying on it, besides the fact that it's hard to count, and besides the fact that it doesn't appear to last as long as immunity from vaccination, and besides the fact that Omicron may be able to get around it, the other problem is that for people to get natural immunity, they have to risk getting seriously ill, hospitalized, or even dying. So we do need to think about it when we think about what constitutes herd immunity. But there's so many people that are at risk right now and at risk of serious outcomes that we're just not there yet. And we're not that close really yet.
Right. I suppose it would pay to remind folks that the strongest resistance to COVID has been shown to be people who have had COVID and been vaccinated. So even if you have had COVID and you think you have natural immunity, it still pays to get immunized. It still pays to get that that booster shot.
Yeah, and if I could just add, it's like a booster, right? The way this works is your immune system needs a clue about what the enemy looks like. The enemy is a virus. Your immune system needs a clue. It's like, I don't know, be like a wanted poster for your body's, private security system. If you give your private security system a wanted poster that knows what to look for, then when that invader shows up, it can identify it and neutralize it. Without knowing in advance, your immune system doesn't have the head start it needs. The virus gets the head start. That's why you're more at risk for severe illness. Once you've been infected or you've been vaccinated, your immune system is, it's had a chance to see what does this invader look like. It's got some preparation. But over time, your immune system starts to forget a little. Like it just gets a little lazy, whether it was natural infection or whether it was immunization. And if you come back later and, 6 months down the road or whatever, and get immunized, then your immune system, whether its first exposure was natural infection or first exposure was immunization, the booster is great and it gives you way higher levels of antibodies than you would have had right away after the natural infection or right away after your primary series of immunizations. The boosters are really important. So like right now, it's like if you've been vaccinated and it's been more than 6 months or 2 months if you got the J&J, get your booster. If you haven't been vaccinated, get vaccinated.
Right. We should point out as well that boosters do a good job, like you say, doesn't mean that the original vaccine doesn't work. Plenty of vaccines need boosters after varying lengths of time.
Yep,
So
exactly. you know this, almost everybody on this call knows this because they get their tetanus booster every 10 years and they get their flu shot every year. It's a very common situation.
Right. So we're getting some kind of brass tacks questions here. Can we relax the 6-foot constraint in the pews, given that we're requiring masking and vaccination is widely available?
That is a brass tacks question, and one that I think each faith community is or other organization is going to have to discern for itself. You know, I will tell you that at the American Public Health Association conference, everybody had to be vaccinated, everybody had to wear masks, but people were allowed to choose for themselves what kind of physical distancing they were comfortable with. Some people, and they gave us different color lanyards. And if you wore a green lanyard, that meant, yeah, I'm good. You know, give me a hug, that'll be great. And if you wore a yellow lanyard, it was like, I'll just take that elbow bump, thank you. And if you wore a red lanyard, that meant, please give me my 6 feet. You know, I'm happy to see you, but I don't need to get that close. So that's what the American Public Health Association did. I'll tell you, I wore a red lanyard, but you know, that's just me. So you know, what we were saying with you know, groups of people gathering indoors where the vaccination status was unknown or mixed, where you had, in other words, where there were unvaccinated people, we were saying that if you're indoors, you should include both masking and at least 6-foot distancing. If you're outdoors, you should do one or the other. Now, if you know that everybody in that group is fully vaccinated, I guess, you know, it's not unreasonable to say you got to wear a mask, but you don't have to stay 6 feet apart. But I would at a minimum let people who want their 6-foot distance feel like that's fine, that's good. You can do that. And you have to understand you're taking a little more risk. You're taking a little more risk. And most of the people that are there who are vaccinated are unlikely to get sick, or if they get sick, they're likely to have a mild illness. But if they've got some underlying health condition, that may not be the case. And it's possible they could take it home or take it to the workplace and give it to someone who's not vaccinated. So that's a gray area. I just ask people to be thoughtful about it, talk with people, come up with a consensus, and give people the option to be a little more careful if they wish to.
Okay. And we, go ahead, Brianna.
I say one of the things I think about as you're talking, and you talked about this idea of risk, and I really liked, you said you were going to refer to our returning to church materials, but I'm going to refer to that because I found it really helpful in talking to congregations of, I think sometimes we like get back to the very beginning of the pandemic when we didn't know anything. And so we're like, we want as low risk as possible, like shut it all down. We're going to stay home. We're going to do nothing. And we realize like, that's not a reality. We can't shut it all down now. And that people have different levels of risk. And so we've talked a lot about layering mitigations and to say, how do we like, don't just do one, but also you might not be able to enforce all of them. And so how can you enforce as many, or like not enforce, that sounds really strong. How can you encourage as many as possible and continuing to layer all of those different things that can help reduce the risk? Yeah. So I just wanted to highlight that.
Yeah, I guess I would say to the pastors in the audience that we ask these things as though they're technical questions, and we should really be asking them as though they're ethical questions. How much risk are we willing to accept, not just for ourselves, but for the people in the community around us or for those vulnerable members of our community? How much risk are we willing to put those people under? And are there ways that we can minimize that risk without placing an undue burden on the life of our congregation. I see that Kathleen R has a question about what acceptable space would be in a congregation, in a sanctuary, and I guess I would suggest that you think about that in those ethical terms. Measure out how many people can we safely cluster, given so much distance, and how much of this are we willing to do on Christmas Eve, knowing that might put some people at risk. And I'm sorry, I'm talking too much here, and I'll let the expert weigh in on this. We get lots and lots of questions about singing and whether that's safe or what kind of precautions we should take. If you have any suggestions along those lines, we'd be happy to hear them.
Well, first of all, I want to say that y'all are the experts on what happens in your houses of worship, not me. I do have some public health expertise, but we're all in this together. So I'm glad when you bring your expertise to bear, Dan. Thank you for that. To talk about singing, I'd like to go back actually to the WCC Returning to Church document. So that really does, the 3.0 version really does continue to stand the test of time, in my opinion. And it set aside this framework of safest, safer, and unsafe, right? And so just to remind you, if you haven't looked at it recently, safest would be when we get to vaccination rates that are over 70%. As a reminder, right now we're just under 56%, just about 56%. And safest also requires that viral transmission is less than 1 case per 100,000 per day. Right now we're at 50, and it requires positive tests less than 5. And right now, as I said, we're over 13. So we're not in that safest category anywhere near it. The safer category is vaccination rates between 50 and 70%. Okay, we make that. We're in that now. And new cases of viral transmission between 5 and 10 cases per 100,000 per day. Remember, we're at 50, and positive tests under 10, and remember, we're at 13. So we're actually not even in the safer right now. We're in the unsafe to gather without mitigations because of our high viral transmission rate and our high test positivity. So if you go and look further down the document into the table about adding mitigations, and you look at I'm just scrolling down a little farther, hang on a second, about mitigating higher risk activities, under singing, if it basically says, I'm reading, you should avoid singing until the safest levels are met. We're a long ways from that. The make it safer, the middle category would be just a song leader, not assembly singing, or low volume humming by masked assembly. So, if you're wearing masks and you've got some distance and people are humming along, I think the chances of, a single soloist in the front, being infectious at any given hour of the week are probably pretty low, especially if they're feeling well. You should make sure that people stay home if they're not feeling well. But you start to get a large choir, that's a little different story. And then you certainly a different story if you've got your whole assembly. So it's just I just keep coming back to the problem right now is there's just a lot of virus around. When it gets lower, it'll be safer. Singing is one of the best ways that you can aerosolize this virus and spread it to lots of other people. The only other really good way I can think of is, yelling at the top of your lungs like you might do in a sports bar or something. So, just keep it in mind. It's really risky.
People often say, well, everyone in the choir or wherever is wearing a mask. Shouldn't that do something? And it does, but unless it really seals off around your nose and mouth, it doesn't prevent the virus from getting out and into the air around you. You have to have a really tight seal.
Especially when you're engaged in an activity that creates such heavy aerosols like singing. A mask is going to be terrific. A reasonable mask is going to be terrific at keeping your aerosols from spreading to others if you're just breathing, which does create aerosols. It'll be a little less effective if you're talking. It'll be a lot less effective if you're singing. A better mask is an N95 or some of the KN95s, although there's a lot of counterfeit KN95s out there. But a lot of people I know that are trying to be very safe about COVID are wearing N95s, myself included. I wear one at the grocery store. They're very available, and it's not like they're in a shortage anymore like they were a year ago or 2 years ago. Well, almost 2 years ago. But they are uncomfortable. They're hot. My glasses fog up. They rub on my nose. Like it's not pleasant. I wore one all the way from Milwaukee to Denver when I went to the conference, and by the time I got to my hotel, I was like really glad to get it off. So it's not a good option for everyone. But on the other hand, the other thing you see with masking is people aren't even if they're wearing a regular medical grade cloth mask, they're not wearing it properly some of the time. They got it under their nose or under their chin. But that's just performative. That's not helpful.
Right. We've gotten a couple of questions about low touch recommendations. Can we bring back offering plates, friendship pads? It seems like touching isn't necessarily the big deal that it used to be.
Well, it's true that we're a lot less concerned about contaminated surfaces and spreading of the virus through contaminated surfaces, and a lot more concerned about aerosols and droplets, but mostly aerosols. So I think, honestly, if you're trying to decide, to get back to the point about layered mitigation, if you're trying to decide between, should I allow my assembly to start singing or should I pass the offertory plate? I want to do one. I'll pass the offertory plate. Yeah, definitely. So like this risk budget, I think the returning to church document talks about a risk budget, and thinking about it that way, because these risks are all adding up. I do think people are pretty clear now that when the UPS driver brings you a package, you just don't have to worry so much about it. So, I would point out that there's just one UPS driver, that's handling that package in the last 24 hours, whereas you might have 100 or more people handling the offertory plate in a space of 5 minutes. So it's a little different, but in general, yeah, I'm less concerned about that. I think the only thing I would say is, once again, there may be people in your faith communities that are less comfortable than others with things of sharing surfaces. And if you're going to, put some of these things back into play that, are more shared surfacey sorts of things like an offertory plate, maybe thinking about how you're going to make space for the people who aren't that comfortable with that.
I think that's a super important reminder. I think about, I've been slowly returning to church. I've started to preach in some spaces and visited a few churches. And I've been one of those people who's a little more cautious. And I found myself in a church, like at a church one Sunday, I was like, okay, like, I know that's less safe, but I'm okay. I'm okay with that. And then they did something that I was did not feel safe at all doing. And kind of had this moment of like, I'm not going, like, I don't want to go back because that felt so unsafe. And I felt really high pressure to participate because everyone else was doing it. And so I think that like, there's like the brass tacks things, there's the sciencey things, and then there's the sociological, like, how do you help to like make sure that there is space for people to not go along with the crowd or to be welcomed even when it seems like everyone else has a different opinion, and create like holding that tension. And it's really hard. And that's what we're dealing with. So I just want to name that too, because I know many of the people watching who are in local churches are struggling with that.
Yeah,
Yeah,
I think Eldana in the comments raises a good point, which is, yeah, it's great to pass the plate or that pad, but we shouldn't be lingering near one another for very long. Looks like you were going to agree with that.
I was going to definitely strongly agree with that. And it also brings up the point that, you know, like as you start to discern what aspects of your traditional worship you want to bring back, that you've kind of put a hold on for safety's sake. Also keeping in mind that people, you know, a lot of people have normalized their behavior in a lot of other aspects of their lives. A lot of people are going to restaurants now, they're going to the theater, they're going to this and that and the next thing. And some people aren't. And there's a lot of virus around there. And when you start to normalize something, there'll be more pressure to normalize everything else. And that doesn't mean, in my view, that you shouldn't normalize something like passing the offertory plate, if you want to use that for an example. But it does mean, as Eldana suggests, that you need to be on guard for people to say, oh, well, that's normal, now everything's normal. Well, no, everything's not normal.
Right. So I know we get questions about Christmas Eve. Maybe that means you share the light with one another, but after church, don't hang out in the narthex wishing each other Merry Christmas. Just go home. Let's see. And since we're on that kind of topic, Joyce has a more of a vent than a question that's been hanging there for a little while. Since our county has only just reached 50% vaccination, but the congregation is at 90 to 95% vaccinated, members of the congregation feel we're already at the way it's going to be and are resistant to continuing to wear face masks, socially distancing, and et cetera, because that's not happening in the community around us. It seems like people have stopped listening to the need to continue those precautions.
Well, I agree. That's my observation as well. I think a lot of people have stopped listening, and at the same time, you know, you're seeing now with Omicron in particular, a number of local jurisdictions are, well, they're not. A lot of them are not putting mask mandates back in place, but they're really ramping up their mask advisories, making them very strongly worded, and you know, for vaccinated as well as unvaccinated people. And there's really good reason for that. And so, you know, I think I'll just get philosophical for a second. I think it's, you know, it's a challenge of leadership. Leaders can't get too far ahead, because then we lose people, but we have to be ahead. Like, and so, you know, your local small p politics better than I do, but you know, the virus does not care about our perceptions. The virus cares about our behavior. And when we come into close contact with each other, it gives the virus an opportunity. And there's just so much around right now. Every part of the state is either very high or critically high. And it's, you know, if there's any way to persuade your members, your people to be more careful with each other in your faith community, to me, this is, you know, when I go to a bar, I have a very minimal responsibility for the care of other people. But that is a lot different when I go to my faith community. I have a high level of responsibility for the people around me. It's a moral argument in my mind as well as much as a public health argument. Again, all of them may be vaccinated. They may be themselves at low risk, but the other people in their lives that they're interacting with don't share that low risk.
Right, right. Barbara asks, would you require volunteers preparing food for public consumption, community meals packaged to go, for example, to be vaccinated or to show a negative COVID test?
Well, that is another one of these questions that has to be answered, on a case-by-case basis on the ground. But if you're asking me to sort of prioritize things, again, you're sort of back to the question of what's the risk of transmitting COVID through contaminated surfaces. And you don't get COVID by eating food that someone's coughed on. You might get COVID by touching a carry-out box that someone's coughed on and then rubbing your eyes. Yeah, you might, but it's not the food preparation that's really the issue. So to me, that's low. On the other hand, if you've got people that are working together, volunteers that are working as a group, okay, it would be great if they were all vaccinated. Should you mandate it? I don't know. But it's as much about protecting them as it is about protecting the people that are getting the meals. Now, if they're hand delivering the meals, that's another question too. To me, an even more important issue. Now, there's a lot of COVID that's transmitted by people who don't feel sick. So what I'm about to say is not a panacea, but it's a more important issue is emphasizing how incredibly important it is for people to stay home if they're feeling not well, even a little not well. Stay home. Don't come to church. Don't come to your volunteer thing. We have to make it easy for people. We don't want them to feel guilty, lose face, feel like they're not, holding up their commitment, none of that stuff. If they're not feeling well, I'd much more highly prioritize that issue than mandating that people get vaccinated.
Excellent answer.
I was gonna say, I love that reminder. I know I was in some conversations with clergy at one point who were trying to figure out all these things. And one of the things we emphasized, we said, make a plan now for what happens on Sunday morning when you wake up with some sniffles, so that you aren't like, oh, should I go in? Should I not? Just make it clear that I'm not coming. This is me practicing safety, and that your staff parish, PPRC, whatever your kind of human resources committee is on board with that, your leadership team, that this is how we build these policies into our system. We did have one more question that I think kind of got lost a little bit. Someone asked about youth lock-ins and overnight retreats for youth. Oh, I think we might know the answer just based on your face.
My poker face gave me away again. So we've had a lot of the growth in viral transmission has been among young people, and there's a couple reasons for that. And one is that on average, younger age groups have lower vaccination rates overall as a broad average, right? I'm not talking about any small group of people, but on average. And the second is that young people don't on average think about risk the same way that older people do. You see this in a lot of ways, right? So there's a lot of transmission among young people. So again, I don't think I can sit here and give you a one size fits all, this is what you should do sort of edict. But it's kind of a thing that you're probably going to need to discern with your own congregation, with the parents. And, you're going to have some parents that are going to be not worried at all about that, some that are very worried. What are we going to do for, youth that have, underlying medical conditions? Some of them will, or, are just, more worried about, or have a grandparent at home, or who knows what. So it's having having teenagers kind of, physically all over each other is a good way to spread COVID. I'm not saying, don't ever do it under any circumstances, but I'm saying it is risky for sure. And again, keep in mind, it may not be so like statistically high risk for the youth themselves. Most young people who get sick do fine, although some don't and some die, right? The numbers are low, very low, but non-zero. And every death that's preventable is a tragedy. At least as important, again, I keep coming back to this, are the people that they hang out with at home, in school, maybe they've got a job somewhere, they've got grandparents. Remember that a 70-year-old who is fully vaccinated is still at higher risk of severe complications or death than an unvaccinated teenager. So like we're really, we're how did Martin Luther King Jr. put it? In a inescapable web of destiny. Like we're all tied together, right? I'm sorry, I don't remember the exact words. A mutual web, a web of mutuality. Like everybody is connected to everybody else. And so it's hard to separate out and say, we're going to be very careful here and we're just not going to worry about it here.
Right. And when you prevent illness in the children, you prevent it in the older adults because kids, under the age of 5 cannot be vaccinated, and the rates are lower between 5 and 11 and 11 and 18. When you stop it there, it's like closing the window so the smoke doesn't get in. If that makes any sense. We're creeping up on 4 o'clock here, and I know that Brianna has one last question. Do we have others that we need to get in before we hit it?
I do see one in the Q&A from Kathleen. I'm trying to see if I can be helpful with trying to gauge the technical issues about how many people it's safe to have in our sanctuary, mask and distance. It is challenging, right? And there are people that, you could call someone from your local health department and have them come out and look and do a walkthrough with you. If they're not too busy, I'm sure they'd be willing to do it. But, broadly speaking, I think, if you've got, I'm just off the top of my head, if you've got, fewer than 50 or, certainly fewer than 50 and maybe fewer than 100 people, and you've got enough room to have everybody at least 6 feet apart from each other, households can be together. That's enough. That's good. If you can space that out, that meets the technical definition. Once you start getting a larger mass of people in a space, then it becomes harder to say if it's safe, even with distancing, because there's just so many people and aerosols can travel so far. Then you have to start to look at, your air exchanges and do you have HEPA filtration and that kind of thing. So it does get a little more technical. So maybe someone at your local health department can help you with that. Or, if you want to contact the WCC, I can try to connect you with someone offline to look into that further.
Yeah. Yes, certainly. If you have, I put this in the chat, but I'll say it here. Kathleen, if you or anyone has those kinds of questions, feel free to email me, and we can get those answered for you.
So my last question is, I think, it's a theme that I've seen, and it came up even today. It's like we're moving towards Christmas Eve. As Christians, this is our second biggest holiday, though sometimes it's even bigger than our first bigger holiday of Easter. It is one that takes place indoors, has traditions around it. People gather. It's often one of the biggest Sundays of the year. We also have Omicron. I am terrible at saying Omicron. I add an N in there every time. I've literally been practicing for 24 hours and fail.
Omicron is how you would say it in Greek. So there you go.
know if you'd say Omicron. I should say Omicron. Omicron.
But so we've got this new variant. We've got one of our biggest holidays coming up. Like, if you were to give someone like just a quick snippet of like, what should people be thinking about as we head towards Christmas as pastors and churches? And
really, you saved the easy one for last. Thanks for that. I appreciate that. Well, look, I mean, first I just want to acknowledge how difficult this is, and not just the first Christmas Eve, but this is the second one now. It's when is this all going to end? It's a really great question. It's so frustrating, and I don't know when it's going to end. All I can tell you is two things. One, it will sometime, and two, it's not close now. So, we, like, people of faith, I think, have an important perspective on how we are to be in relation with each other and how we are to care for our brothers and sisters and about sacrifice. And sacrifice isn't, like, right now something that's theoretically a good idea. We have to give up some things to keep each other safe. And that doesn't mean we have to give up everything and nowhere close to it. But it does mean it's going to be a fair amount of work to try to discern what's our risk budget and how are we caring for the least of us, the most vulnerable of us among us.
Thank you.
And I have said it many, many times since this pandemic began, how glad I am not to have been leading a congregation through it, because, what a nightmare. And trust me, folks,
important work. People.
Yes, we at the WCC understand and appreciate the difficulty of your situation. And I'm really glad that Dr. Swain is also gets it. So thank you, Geoff, for coming this afternoon. Everyone give Geoff a round of applause in the comments there. Are there any last words that you'd care to share?
I appreciate your invitation. Thank you for everything you've been doing. I've said this to Reverend Parker, and I'll say it to all of you. This is meant as a compliment, by the way. Y'all are public health folks. You're my people. You are the people. I'm a public health person. You are the people that are keeping a lot of folks safe. You are the trusted messengers. You're the people that people believe and listen to. We public health, official, formal public health people cannot do it without you. We're so grateful. So thanks for all you're doing, and let's continue to stay in relation.
Hey, there's a great note to end on. There has been some polling done recently that indicates that churches that share information about COVID and vaccination and do these practices build trust in their community. So if you want your community to look at you as leaders, here you go. Here's your opportunity. Thank you all. If you have any questions, get in touch with us. Otherwise, we're hoping to put out a one-page guide for Christmas, and we'll get that out soon to you. And have a safe and happy Christmas.